Hello and good morning. You've reached the ICER meeting on treatments for obesity management, effectiveness and value. This is a meeting of the New England Comparative Effectiveness Public Advisory Council. We will be starting in approximately 1 minute to give people time to log in. So stay tuned and we'll be starting again in about 1 minute.
Hi, good morning. My name is Dr. Jason Waspy. I am the chair of New England CEPAC, and I'm delighted to have all of you here today for what I know will be a critically important meeting and an important discussion of both effectiveness and value. I am an associate professor of medicine at Harvard Medical School, and I am a cardiologist at the Massachusetts General Hospital. I direct our program in health services research in heart disease. So at the beginning of every meeting, we introduce the New England CEPAC, and in the setting of wanting to ensure that all speakers disclose any financial relationships with industry, each member of our CEPAC panel who is present today has met the conflict of interest policy as defined by ICER. So when I introduce, I'm going to have each CEPAC member introduce themselves, maybe say briefly about your work, and note whether you have any updates to this declaration. And I'm going through just by alphabetical order since we're not in person today. So I'd love to start with Dr. Rob Azeltine.
Good morning. I'm Rob Azeltine, professor and chair of the Division of Behavioral Sciences and Community Health at the University of Connecticut Health Center. Also direct the Center for Population Health there. I'm a medical sociologist with majority of my research in mental health and suicidal behavior, and I have no update to my conflicts.
Thank you so much, Rob. Dr. Austin Fracht.
Hi, I'm Austin Fracht. I'm a health economist and director of the Partnered Evidence-Based Policy Resource Center at the VA Boston Healthcare System. I'm also a professor at the Boston University School of Public Health and a principal research scientist at the Harvard University School of Public Health. I have no additional conflicts of interest to report.
Dr. Martha Gold.
Good morning. I'm Dr. Martha Gold. I'm a family practitioner by training and a public health practitioner by career. And I'm professor of emerita of CUNY School of Medicine. I have no updates to conflicts and no conflicts.
Thank you so much. Megan Golden.
Hi, I'm Megan Golden. I'm the co-founder and CEO of the patient advocacy organization Mission Cure. We are focused on pancreatitis, and I have no additional conflicts.
Rebecca Kirsch.
Good morning. I'm Rebecca Kirsch, Executive Vice President of Policy and Programs for the National Patient Advocate Foundation. No conflicts or adjustments to my disclosures.
Thank you. Dr. Steve Kogut.
Morning, everybody. I'm Steve Kogut. I'm a pharmacist and professor at the University of Rhode Island in the Colleges of Pharmacy and Business. And my teaching and research activities are in the areas of managed care pharmacy, pharmacoeconomics, and medication use. I have no updates to my conflicts of interest to report.
Thank you, Steve. Don Kreis.
Good morning, everybody. I am Don Crease. I am New Hampshire's consumer advocate, which means that I dwell in the world of prices of regulated public utilities. But I'm really here today as part of the patient community because I successfully raised an awesome 20-year-old daughter who is living and thriving with cystic fibrosis. And I have no updates to my previous disclosures, and I have no conflicts.
Thanks so much, Don. Dr. Tara Lavelle.
Hi, good morning, everyone. I am assistant professor and health economist at Tufts Medical Center in Boston, and I have no updates to my conflict of interest.
Thank you. Dr. Greg Lowe.
Good morning, I'm Greg Lowe. I'm a pharmacist and pharmacoepidemiologist, and I'm the director of the Mass General Physicians Organization's pharmacy program. And no updates to my conflicts, thanks.
Thanks, Greg. Dr. Lefterios Mylanakis.
Good morning. I'm Director of Infectious Diseases at Brown and the Professor of Medicine at Brown, and I also have no updates to my COIs. Thank you.
Thank you. Dr. Stephanie Nichols.
Good morning. I am an associate professor in the UNE School of Pharmacy up here in Maine. I am also an adjunct assistant clinical professor in the Tufts School of Medicine in the area of psychiatry. I am a board certified psychiatric pharmacist. I specialize in substance use disorders, and I also just recently achieved my MPH. I'm excited to be here.
Congratulations, Stephanie, and great to see you. Dr. Jason Schwartz.
Good morning, I'm Jason Schwartz. I'm an associate professor of health policy at the Yale University School of Public Health. My research looks at regulatory and policy-making activities around pharmaceuticals and vaccines and other medical technologies, and I have no conflicts.
Thank you, Jason. And last but not least, Reverend Al Whitaker.
Yes, good morning, Albert Whitaker. I am currently Director for Community Impact with the American Heart Association and also serve as pastor of a local church in the Boston area, St. Mark Congregational Church. And I have no conflicts of interest.
Thank you, and thank you all for being here for the session. I would like to next transition to 4 patient experts and clinical experts who will introduce themselves, and please declare any financial or other conflicts of interest after your introduction. So starting with Dr. Scott Kahan.
Hi, Scott Kahan. For the purposes of this meeting, my primary role is as an obesity medicine clinician. I have several academic appointments, most primarily at Johns Hopkins Bloomberg School of Public Health. And I have consulted to all the companies at one point or another involved in this review, although of late, not as much purposely because of some guidelines committees that I'm on, but over time I've consulted to all of them.
Thank you, and thank you for joining us today. Next is Dr. Lee Kaplan. Oh, Lee, your microphone's not on.
Good morning. I'm speaking to you from Europe, so if I get a little tired, it's because it's going to be late in the day. I am the founder of the MGH Weight Center, from which I've recently stepped down, and I'm an associate professor of medicine at Harvard Medical School, trained as a gastroenterologist, and my research is focused on mechanisms of action of both obesity and the genetics of obesity. I'm here as primarily as an obesity medicine clinician, and my conflicts of interest is like Dr. Kahan. I've worked with all of the companies in this space, or most of the companies in this space, as well as several health systems, several universities, and several government organizations.
Lee, thank you so much. We'll have to get you a coffee if we'll go long. We'll have to see how it goes. Thank you for joining the time zone. Next is Nikki Massey.
Morning, everybody. I'm here to represent the patient perspective. I am a 14 and a half year post-op of bariatric surgery and obesity advocate. I am a member of the National Board of the Obesity Action Coalition, and I don't have any further disclosures other than what's on the slide.
Thank you so much, and thank you for joining us and providing your perspective. Last, but again, not least, is Joe Nadolskowski.
Hi, I'm Joe Naglowski. Like Nikki, I'm a patient advocate living with obesity since around 20 years of age. I manage the Obesity Action Coalition, which is the patient advocacy organization in the US. OAC's policies don't allow me to have any personal relationships with industry, but as disclosed on the side, OAC does accept some funding, including funding from many of the manufacturers of the medications that are going to be talked about today.
Thank you so much, and thank you for joining us. And so I just would close by saying that obviously disclosures of financial conflicts of interest are very important in this setting. And so would request that later in the day, as the day goes on, if there are other speakers, including people on the policy roundtable or any public commenters, please announce any financial relationships with industry or other potential conflicts of interest or influences on judgment. We will also present this information publicly on the slides when people are talking. So with that, I'd like to introduce Dr. Steve Pearson, who is the president of ICER.
Thanks, Jason, and thank you again to the patient and the clinical experts who are joining us today and who have informed our work since the beginning. I'm just going to have a very brief intro to the meeting, and we'd like to start with kind of a clarification around some of the reasons that we are here today. And that starts with the unmet need of patients and families. So let me read you a quote from a person with obesity. I grew up with obesity and I felt like I was diagnosed twice, once in a doctor's office, and again as schoolyard bullies identified me as the fat kid. On a day-to-day basis, I wasn't as concerned about the number on the scale, more so how I was perceived by others. Teachers assumed I was lazy. Doctors reduced any issue I faced to my weight. I experienced these feelings in professional settings as well. During job interviews, for instance, when it was questioned whether I could keep up with my peers. So I think obesity is not obviously a rare disease by any means. And the perspective of patients has been and will be a very important centering kind of framing for us today. So the reason we're here is to talk about that, and in some ways to talk about what happens when new treatments for conditions like obesity are approved by the FDA. And in short, what happens is a sense of celebration. I mean, often there is a sense that there have been years, decades even, of research, of investment, of risk-taking, and that includes companies. It also includes individuals and families who participated in clinical trials and the clinical research community. And so when all of that effort produces a new treatment that can help patients, there is a recognizable and a completely reasonable sense of celebration. Other things happen too, though, the day that FDA approves something, because at that stage, there are always still questions. There are questions about, really still what are the risks and benefits, because, there have been clinical trials, but there's always some degree of uncertainty, and especially around which patients are most likely to benefit. There are some questions frequently around how the new treatments fit into the evolving landscape of other treatment options. Does it come first? Does it come later? And, the pricing is an issue, because from day one, after the FDA approves it, once it goes into clinical practice, the price has to be set. And people start to question, what are the reasonable prices, both to the system, but also obviously to patients and to the government, to the extent that they pay for medications as well. We're also always sensitive to the idea that we're learning as we go, and that we have to think about, what lessons have we learned from the development of a new treatment or treatments, and how does that kind of position us to do better going forward, either in the development of the evidence, in the targeting of the types of treatments that we're trying to develop, and in how we price and cover them through insurance. So all of that is part of why we're here today to talk about the exciting developments in the area of treatments for obesity. Another reason we're here today is because none of this happens in a vacuum. And we are going to be talking about fair prices, and fair insurance coverage for these treatments for patients living with obesity. But we also have to remember that in the backdrop, we've got a healthcare system where rising healthcare costs affect everybody, and some people more than others. Now, these folks featured here were just some of the patients and families that were featured in an article that came out from Kaiser Health News after a survey and a kind of a study done by the Kaiser Family Foundation. And it just highlighted the burden of healthcare costs on people. And it includes everything from not being able to pay for their treatments to not being able to afford insurance itself. The family on the left, Marcus and Allison Ward from Chicago, their twins were born prematurely. And through a variety of different problems with their insurance, the costs became unmanageable. And they had to leave their hometown and move to live near family so that they could afford, if you will, paying for their medical bills and the rest of their life. Sam and Ariane Buck in the middle still live, I think, in Arizona. And they're kind of a classic American story of two employed people whose health insurance just fell through the cracks when they were between jobs. And one of them both of them ended up in the emergency room and ended up with medical bills that they have been struggling to pay. And they are one of the many millions of Americans who, according to this survey, have had to either themselves not seek medical care or been turned away from medical institutions because of an existing medical debt. The survey, by the way, said that 100 million Americans, by extrapolating from this 3,000 person survey, 100 million Americans are currently living with medical debt. It's either on their credit cards and they're trying to pay it off, or they're in receivership and people are trying to come and find it. And of that 100 million, 1 in 7 reported that they had been turned away from a doctor's office or a hospital setting because of their existing medical debt. And this has negative health consequences. The woman on the right is another unfortunate story. She retired early and was on retiree health benefits when she ended up in the hospital and went over the $1 million cap on her retiree health benefits. She had to declare medical bankruptcy, which is still the leading cause of bankruptcy in the United States. So these are real people, real stories. And so, yes, we are going to be talking about people living with obesity, and our attention around their unmet need and the things that we can do for them and should do for them will be center of our attention today. But around them, around all of us, is a community. They don't have to be our health plan members. They're just part of our community. And we have to remember that we're here today in part because there has to be a balance in the affordability of health insurance and of what we ask patients to pay out of pocket so that we can help the patients in the middle create innovative new treatments and keep that pipeline humming while making sure that overall we create a system that doesn't inadvertently hurt people who are not in the room today by the increases in healthcare costs out of proportion to the health benefits that we are getting from these new treatments. So that's the balance, if you will. It's not kind of a winner take all, but it is a balance. And we all recognize it at some level, but that's part of the reason that we are here today to talk about the evidence, to talk about the value, and talk about how we get this right going forward. So you've heard from the members and been introduced to the members of the New England Comparative Effectiveness Public Advisory Council. Briefly, let me tell you about ICER, which is the convening host today. So our sources of funding are kept updated on our website in this pie chart. Currently, we receive about 69% of our overall revenue from nonprofit foundations. The primary funder there is the Laura and John Arnold Foundation, but we also have several others, California Healthcare Foundation, Commonwealth Foundation, and others. About 25%, as you see, 25% is gathered directly from life science companies, from manufacturers, and from health plans and provider groups. And that goes to a specific ICER policy summit that we hold for them and other activities related to that are kind of kept separate from our funding for the research and the meetings that we hold, such as those today. We also receive, as you can see, small, relatively small amounts from subscriptions to our ICER Analytics cloud platform and from government and individual philanthropy. So the ICER report that serves as the kind of academic, if you will, backdrop for today starts about 8 months ago, and it begins with a very intensive phase that we call scoping. And that means that, again, even though we all think we know everything about obesity, we really start to talk first to patients and clinical experts. We talk to manufacturers and other stakeholders, but the goal is to say, tell us about the diversity of the experience that we might be missing. Tell us about what matters most to patients, about the value of treatments or their overall care. Tell us about the arc of innovation, where these treatments are coming from, where they're going, where are we in time, if you will, in that innovative kind of timeline. So we do that, and then after having been grounded in that, we go look for the evidence, and it's in the peer-reviewed literature, but it could be from patient-reported surveys, it could be in other areas, and we're very open to try to find and work with evidence from a variety of different sources. We do an evidence kind of evaluation on the clinical side, and we work frequently with outside academic cost-effective experts, in this case from the University of Illinois at Chicago, to develop a cost-effectiveness model to help us think about the long-term value for money. This whole process goes through several iterations, multiple iterations and touch points with the manufacturers and patients and clinical experts, but a formal process also with public comment and revision. And we are also very grateful to have expert reviewers. Sometimes they are part of the meeting today, sometimes not, but you can see the names here: Dr. Harold Bays, Dr. Joe Naglowski, and Fatima Cody Stanford, all of whom helped us in terms of providing comments on the draft report. How is the evidence in that report structured to support our discussion today about value as a broad concept? Well, it starts in terms of our framework. It builds up to an overall consideration around long-term value for money, but it has different components. At the base here, if you will, in green, it starts with, we look obviously to see whether treatments can help us live a longer life. And how long would that life addition be? But many treatments don't or have a marginal effect on that. And many treatments instead, or in addition, help us return to better function. They have fewer side effects than other treatment options. There are other ways that they can provide health benefits to patients and to families. When we look at costs as part of this kind of first pass, if you will, of the cost effectiveness model, it is total cost, not just the drug cost, but we really try to capture, and the evidence is sometimes or frequently not there, but we're really trying to say, if the costs are, we're spending for this pill here, but does it help us reduce the costs for hospital visits later, or for surgeries later, or for other drugs that might be needed later? So what are the overall effects of costs? And then we have important elements of value for money that, in a sense, are beyond or complementary to some of the things that we can capture in clinical trials and cost effectiveness models. And so we call them potential other benefits or benefits beyond health. Those are, again, the benefits, potential benefits of a drug or any other kind of intervention that spill over or that somehow encapsulate a larger framing of the benefits to patients at their work or in how families can manage their lives with better treatments. And the special social or ethical priorities at the top, in some ways, is something that kind of envelops the entire chain here. It's thinking again about, are there special effects of treatment on our overall social goals of trying to reduce disparities? Is this a particularly severe life-threatening condition for which we might want to give greater priority to the added benefits because they're so critical at the margin? So we try to take that into consideration, and these elements are in the report, but they're also hardwired into the discussion and the voting that you'll hear today. So with that, let me just give a very brief overview of the agenda, where with this brief intro, we'll dive right into a presentation and discussion of the evidence. We will have public comments and discussion, followed by lunch at around noon Eastern. And then the CEPAC will return for further deliberation and voting throughout all of this with the clinical experts and the patient experts at the table and contributing. And then following that, we will have a brief break before the policy roundtable, table, where we will really look forward and try to frame our questions around how do we get this right? If the goal is that balanced picture of innovation within an affordable landscape, how do we get that right? Through pricing, through coverage determinations, through future research, and through the interactions of clinicians, patients, and families. What do we need to do to try to get it right? So we'll finish up around 4 o'clock with final comments from our policy roundtable members and the CEPAC itself. So with that as an introduction, let me hand it over now to Dr. Atlas, who will start the presentation of the clinical evidence. Steve.
Good morning, everyone. I'm Stephen Atlas, and I'm an associate professor at Harvard Medical School, and I'm also a primary care internist at Massachusetts General Hospital. Next slide, please. Emily Nahn, Molly Beinfeld, and Victoria Lancaster were instrumental in putting together the data that I will present, and my disclosures are listed here. I have no major disclosures to report. Next slide. So obesity is a common chronic condition that increases one's health risk for diabetes, high blood pressure, arthritis, cancer, heart disease, and even death. More than 40% of adults in the United States currently have obesity, and this is projected to increase over time to 50% by 2030. Obesity is even more common among certain racial and ethnic groups, such as Hispanic adults and non-Hispanic Black women. And the annual costs attributed to obesity are staggering, estimated to be $260 billion each year in the United States. Next slide, please. Obesity is commonly assessed using body mass index, as it's easy to reliably measure since it's a calculation of weight and height, as shown here, and it correlates with total body fat. The goal of therapy for obesity is to broadly prevent, treat, or reverse its complications, including its impact on quality of life. For most, the initial weight loss treatments focus on lifestyle interventions, and these include things like healthful nutrition, increased physical activity, and behavioral modifications. Though helpful for some, weight loss with these lifestyle modifications are usually modest, and weight regain occurs in the vast majority of individuals. Moreover, for individuals not achieving these desired weight loss, medications are often considered to promote weight loss before more invasive treatments are considered, such as surgery. Next slide, please. In our discussions with patients, they pointed to many impacts of obesity. They highlighted the profound physical and mental impact on patients' lives, including education, work, relationships, as well as a strong social stigma associated with obesity. This stigma can make individuals with obesity feel judged, shamed, and ostracized, and may impact their willingness to engage with healthcare providers around weight loss and the consequences of obesity. Patients identified a need for new therapeutic options and broadly recognized that no one treatment is a panacea for all. And this reflects both the various factors that lead to obesity, as well as the fact that virtually all of these treatments have side effects for individuals. Patients also recognize that for those who respond to medications, they need to be taken long-term. So chronic use is needed to maintain the weight loss that may be achieved. And finally, they all focused on the affordability of increasingly expensive treatments, many of which may not be covered by their health insurance plan. Next slide, please. So with that as a background, the scope of our review focused on adults actively seeking medical management for weight loss and meeting criteria for obesity, which is a body mass index of greater than or equal to 30, or who are deemed overweight with a body mass index of greater than or equal to 27, but also have at least one health-related comorbid condition, such as high blood pressure. We assessed the clinical effectiveness of 4 drugs: semaglutide, liraglutide, phentermine, topiramate, bupropion, naltrexone. The last 2 are combinations. And we compared each of these treatments individually to the addition of adding it to standard lifestyle management that I've described. We were also interested in comparing semaglutide to the other drugs because as a newer drug that has demonstrated greater weight loss, there's considerable interest in the use of this new medication. We also focused on patients with obesity without pre-existing diabetes as the primary focus, because both for semaglutide and liraglutide, these are drugs that have other indications for treatment of diabetes and may be more appropriate when considered for weight loss in that setting. Next slide, please. So these are the 4 interventions that I spoke about. Semaglutide and liraglutide are both GLP-1 receptor agonists, which is their mechanism of action. They're both given by an injection under the skin. Semaglutide is given once weekly, whereas liraglutide is required to have daily injections. For phentermine, topiramate, and bupropion, naltrexone, both of these are combination drugs. They're given orally, and they each have different mechanisms of action as listed here. They both require once daily dosing with the dosing information shown. Next slide, please. So in terms of the outcomes that we focused on, we looked at outcomes generally over 1 year. The 1-year outcome was focused on the primary outcomes in the trials that we reviewed, and it varied a little bit because each of these drugs have titration periods to reach their maximum dose, which can vary between 4 and 16 weeks, depending on the medicine. We looked at the primary outcomes from the key clinical trials, and these included percentage weight loss from baseline to follow-up, as well as categorical weight loss, i.e. those achieving at least 5% or at least 10% total weight loss over the study period. We also looked at secondary outcomes, such as changes in metabolic or cardiovascular risk factors, such as systolic blood pressure, or measures of blood sugar, such as the hemoglobin A1C, or cholesterol, as measured by the low-density lipoprotein, LDL. We also looked for evidence around health-related quality of life outcomes that were also assessed in the trials. Next slide, please. Turning to the clinical evidence, we conducted a systematic review based on the PICOTS criteria that is provided in the report. We identified 18 trials that were included in the network meta-analyses that I'll be presenting. These included trials with usual care comparators. 13 of these trials focused on patients without diabetes at baseline, and 5 included patients with diabetes. There were also 3 trials, one for each of semaglutide, liraglutide, and bupropion, naltrexone, that included intensive behavioral therapy instead of the standard lifestyle modification I described earlier. The number of trials for each of the drugs is listed here, as well as the number of patients that were included in these trials. As can be seen in terms of age, sex, and BMI, there were differences in the average characteristics across the trials, especially in terms of age and in terms of sex. The level of BMI, most of them in the 37, 38, would indicate sort of what's considered to be a serious or a high level of obesity. Next slide, please. This is a diagram of our network looking at the drug trials that focused on patients without diabetes who were receiving standard lifestyle management. All 4 of the drugs are primarily compared to placebo. The names of the trials are listed here. Of note, next slide, there was only one trial that provided a direct comparison between two agents. And this was a trial that compared liraglutide and semaglutide. So all of the other evidence that we're going to be presenting is comparing the individual drug to standard care plus placebo. Next slide, please. So this presents the results of treatment looking at the outcome, the primary outcome, mean percentage weight loss from baseline to 1 year. And just to orient you, each of the 4 drugs are listed compared to placebo. Focusing on the bottom line, each of these drugs have a negative, meaning they contributed greater weight loss beyond that seen with placebo. For bupropion, naltrexone, and liraglutide, it was an additional 4 to 5% mean weight loss. And it was greater, as you can see, for phentermine topramate, and even greater for semaglutide. As highlighted in bold, all of these were statistically significant in the network. The one exception was comparing liraglutide and bupropion naltrexone for the amount of weight loss. They in the network appeared to have a similar amount of weight loss. Next slide, please. This just presents a summary of the outcomes. So again, all these drugs improved 1-year weight loss outcomes. As I just showed you, this included the percent change from baseline, as well as other analyses that we did that showed them achieving greater, at least 5% or more weight loss compared to placebo with standard lifestyle management. As I noted, the magnitude of weight loss appeared to be greater for semaglutide and phentermine topramate than for liraglutide and bupropion naltrexone. We also did analyses looking at the differences among the drugs, and semaglutide demonstrated greater odds of achieving at least 5% or at least 10% weight loss, and also appeared to be greater in terms of its effects in achieving even higher amounts of weight loss, specifically 15 or 20% weight loss in the trials. In terms of the other outcomes, semaglutide and liraglutide improved systolic blood pressure and blood sugar compared to usual care. Systolic blood pressure was also lower for phentermine topramate than usual care. However, blood sugar results were not reported for either phentermine topramate or bupropion naltrexone trials among patients who did not have diabetes at baseline. Next slide, please. In terms of the patient-reported quality of life outcomes, all of the interventions used a range of different measures to assess for improvements in both physical and mental health function. And this limited our ability to compare outcomes across the different interventions. In general, all of them had a greater impact on physical function than mental health function. And overall, semaglutide, liraglutide, and bupropion naltrexone resulted in greater improvement in physical function across all the health-related quality of life measures that were used compared to patients who only received usual care. Physical function was not assessed in the trials of phentermine topramate, but in general, it did show improvements in mental health function compared to usual care. Next slide, please. Turning to the harms of the treatments, for all of the interventions we looked at, adverse events were commonly reported, but there were few serious harms that were reported in the trials we examined. For each of the drugs we list here, the most common side effects that were reported by patients from the trials. Discontinuation due to adverse events was higher for each intervention compared to patients who received the placebo treatment. Patients taking liraglutide, pentyramine topramate, as well as bupropion naltrexone appeared to have higher discontinuation rates than for semaglutide. Next slide, please. This is depicted better here in our network analysis. And this was looking at the odds of discontinuation due to adverse events. So an odds ratio of 1 would mean that there's no change. An odds ratio of greater than 1 indicates that the treatment would have greater discontinuation than for placebo. And an odds ratio of less than 1 would indicate the opposite, less side discontinuation compared to the alternative. As you can see in the bottom row, each of the different treatments has an odds ratio of greater than 1, indicating more likelihood of discontinuation compared to placebo. Also noted in bold is that for 3 of the drugs, this reached statistical significance. For semaglutide, while it was higher, it included the 95% interval included 1. And then finally, for semaglutide compared to the other 3 interventions, it appeared to have somewhat less side effect leading to discontinuation than the other drugs. But again, these differences were not statistically significant in the network that we performed. Next slide, please. Turning to the controversies and uncertainties, all of these drugs lack long-term efficacy and safety data, including whether weight regain may occur over time despite continued therapy, and importantly, if sustained weight loss leads to decreased clinical endpoints such as cardiovascular events. There's also important differences among the medications in their mechanisms of action that may lead to differences in the clinical endpoints beyond any benefit that could be achieved with the weight loss alone. Specifically, it's unclear if cardiovascular benefits of semaglutide and liraglutide, which have been demonstrated for patients with diabetes, regardless of whether they have obesity or not. So the benefits have been shown in terms of cardiovascular outcomes for these 2 drugs. However, it's uncertain to know whether that same would be seen for patients with their obesity, but who don't have diabetes. Finally, there were important differences that I highlighted earlier in the trials in terms of their size, the patient characteristics among participants, as well as what the lifestyle modification interventions were, the outcomes assessed, the duration of follow-up, and the lack of trials that directly compared one agent to another. Next slide, please. There are other potential benefits and considerations. So semaglutide and liraglutide, as mentioned, are the GLP receptor agonists. And there are other therapies that are under investigation that are investigating these new mechanisms that underlie weight reduction. So the field is changing in terms of our knowledge. These new medications, it's uncertain whether they will lead to sustained weight loss and whether that weight loss may improve quality of life, including things like social interactions with family, friends, educational achievement, and work performance. Again, the data is not there. There's also a disproportionate impact of obesity on certain racial and ethnic groups. And the costs of medications that are not covered by health insurance may exacerbate existing health inequities that we know exist in our system. Next slide, please. We received a large number of public comments, and several important ones are listed here. Though many with obesity are interested in weight loss, some advocated for more efforts focused on managing the medical issues associated with obesity, especially those who've had negative prior experiences with different weight loss treatments. We also heard that for women of childbearing age, weight reduction has the potential to improve fertility, maternal morbidity and mortality, and even infant health. And these have not been adequately studied to date. And finally, as mentioned, existing health inequities may be exacerbated by selectively limiting access to these new medications for those patients who are able to afford them or may have better or inferior access to healthcare providers who can prescribe them. Next slide. So in summary, we felt that the results from the clinical trials and the networks that we examined demonstrate that semaglutide, liraglutide, phentermine topramate, and bupropion naltrexone improve weight loss outcomes of patients with obesity compared to standard lifestyle management. The magnitude of the weight loss appears to be greater for semaglutide and phentermine topramate than for liraglutide and bupropion naltrexone. All four drugs had common adverse events and higher discontinuation rates than placebo, but few serious harms were reported in the trials. And as mentioned, semaglutide may have lower discontinuation rates than for the other drugs. Next slide, please. So our evidence ratings appear here. We'll also revisit these in more detail at the time that the CEPAC panel goes through the voting questions. Broadly, the rating for semaglutide takes into account its impressive weight loss effects and possible cardiovascular benefits. Liraglutide may have similar cardiovascular benefits, but is associated with less weight loss. The evidence for weight loss effects of phentermine topramate is not as strong as for semaglutide. And for bupropion naltrexone, it appears to be associated with less weight loss than semaglutide or phentermine topramate. And for both phentermine topramate and for bupropion naltrexone, there's less certainty about whether weight loss will lead to decreased cardiovascular endpoints or other clinical outcomes. Thank you very much. And we'll now, I'd be glad to take questions and involve our clinical experts.
Steve, thank you so much for that. So for the next 13, 14 minutes or so, we have time for questions from the CEPAC, either for Dr. Atlas or for our clinical patient experts. Just please raise your hand if you have them. And I guess while people are getting warmed up, maybe I'll ask my first question. And this could be either for Steve or Lee or any anyone, any of the experts. I guess I'm struck by the FDA label and the inclusion criteria of the review here, including patients all the way down to a BMI of 27. And so that's a relatively modest BMI in the overweight range. And some of the effect estimates that we're seeing in these trials is a weight loss of 20%. I'm just kind of curious about, I guess maybe this question is more for the clinical experts. What is the goal of therapy? Is it to normalize the BMI to 25, or because a 20% weight reduction for someone who starts out with 27 BMI actually gets them well within the normal range and below 25? I mean, what is the goal of there? Are there specific targets the same way that there are for LDL and A1C and so forth?
Yeah. I'll jump in real quick. The targets are not at all similar to what we would typically do in cholesterol treatment, in blood pressure treatment. There is not clear and consistent evidence that, for example, attaining a BMI of 25 leads to very notable long-term benefits compared with attaining a lowered weight from baseline. So the standard of care and practice is to lower weight a reasonable amount such that patients' health, feeling, and functioning improves. We know that things like blood sugar, and LDL, triglycerides start to improve with a weight loss of on average 3, 4, 5, 6, 7% from baseline weight. More weight loss typically is better, but it's both fairly uncommon that anyone would get down to a BMI of 25, at least not people with significant enough obesity, nor is it necessary to fairly significantly improve health. The other point I'll make is the FDA indication for obesity medication use is a BMI greater than 30 or a BMI down to 27 with obesity associated comorbidities, hypertension notably, hyperlipidemia, diabetes, prediabetes, et cetera. And so for those people that we're going down to treating it at a BMI of 27, those are typically people that have usually more than one weight-related comorbidity. And so in those cases, getting the weight down, whether to a BMI of 25, whether even a bit lower, usually we'll see some pretty impressive improvements in health status and risk factor status.
Thank you. That was very helpful. And I see a couple of questions from my colleagues. I'll start with Steve, Dr. Kogut.
Thanks. I'm interested in the lifestyle modification piece for these medications. Of course, this is a really important component of the intervention. And just wondering about how we should think about the difference between efficacy and effectiveness in how lifestyle modifications in a clinical trial and sort of with protocols and oversight, would work in the real world. So that's my question.
So I'll answer just briefly about the trials, and then maybe Lee, you can talk about how you all do it in clinical practice. But the evidence that I primarily presented is sort of standard lifestyle management, which is sort of this combination of dietary changes, activity recommendations, and some behavioral interventions. There were trials of more intensive lifestyle treatments, and in those trials, the drugs did also show benefit compared to more intensive programs, not sort of the typical stuff, but the amount of weight loss attributed to the drugs was less. But I think your question really is sort of like, how effective are the standard lifestyle modifications as part of the trials compared to what can be done as part of what a doctor may do? Lee, do you have any thoughts on that? You're on mute. Yeah.
It's tough being here in the other side of the world. I keep forgetting to unmute myself. Sorry. I have a couple comments. One is that we do have now good long-term studies, 10-year plus studies of lifestyle modification. And those lifestyle modifications, as was raised already with respect to the drugs, those lifestyle modifications have fairly transient effects. The maximum effects that are seen with the most intensive lifestyle modifications that have been studied formally have been about 7 to 8% at 1 year that degrade with continued lifestyle intervention to about 3.5 to 4% at 4 years. Then they degrade even further after that, but the intensity of the intervention goes down. So it's a moving target, and what we're seeing in these studies is that the lifestyle intervention arms of the placebo arms of the studies all have much less effectiveness than the ones in those large studies that I just cited, which means that the intensity of the lifestyle intervention is less. I think what we can say in clinical practice is that if people get medical intervention, and again, a small minority of people get medical intervention, it is probably somewhat similar to the kind of lifestyle intervention that's in the placebo arms of the studies that you've evaluated and have been included in the network meta-analysis. So I would say that they are fairly equivalent. In real life, there will be patients who get less than that, but I think I don't think there'll be a lot of patients who get more than that. And I think that therefore these data are probably reasonably predictive of what's going to be seen in the real world. The last point I would make about all of this is that if you get to more intensive lifestyle modification, and I particularly cite the STEP 3 trial, very intensive lifestyle modification in the STEP 3 trial led to only 0.5% more ultimate weight loss at 1 year for semaglutide than the normal, less intensive lifestyle modification. And the reason I mention that is as the drugs improve in terms of their efficacy, the effectiveness, the additional effectiveness of lifestyle modification seems to be less. In that same study, that STEP 3 trial, there continued to be very good effectiveness of lifestyle modification in the placebo group, but compared to no intensive lifestyle modification in the semaglutide group, the intensive lifestyle modification only had a tiny effect.
Lee, thank you so much. Stephanie, I see you have a question.
Thank you. This is really fascinating, all of this information. My question is about the route of administration for various treatments. So I'm not sure who it's best for, so I'll just ask it. So we know about 20 to 30% of young adults have needle fear, particularly people with psychiatric conditions, and particularly women. And so since both of those groups are at higher risk of obesity, how do we weigh that information against the different various options, considering some are multiple daily dosing orally, some are injected once a week, some are injected daily. So how do we think about all of those different things?
Maybe I could add something here. I would say that as we do it in real clinical practice, patient preference, the things that we consider in clinical practice in using medications and in choosing medications are, number one, what is the relationship between the medication's mode of action and the risks that the patient have. So some of these medications have certain risks associated with them, and some patients shouldn't be given them. The second thing we consider is, where do we get double benefit? We have drugs like semaglutide and liraglutide, which also treat diabetes. So if a patient has diabetes, we might preferentially consider those. And the same thing is true for each of the other medications under consideration here. The third thing we consider is the patient preference in terms of things like route of administration, frequency of administration, and things like that. And again, this is where your question comes in. The fourth is cost to the patient, and the fifth is average efficacy. And I mentioned that the average efficacy is only number 5, because what's not reflected in the data that you've seen summarized is the enormous variability from individual patient to individual patient. What these studies show is the averages. They show the standard deviations and standard error of the mean, but these are very large studies in the main, and as a result, the standard error of the mean is shrunk down to the point where it's not as appreciable as it might be, that there's enormous patient-to-patient variation. So when it comes back to your question, then, when you think of all those things that we use clinically to go into it, we very much consider with the patient what their response would be in terms of an oral drug versus an injectable drug. The last point I would make about all of this is a nice study by Merck some years ago looked at the issue of insulin injection and the fear that patients have of going on insulin. Many patients in that study reported that the biggest fear was that going on insulin for diabetes reflected failure of everything else. And they were told by their providers that if they didn't do what they were told to do and they failed, the punishment, if you will, would be insulin. And that's how the patients perceived it. And I think that we're moving to a situation now where more and more of the population, for a whole variety of diseases, are on parenteral drugs, injectable drugs. And as a result, my suspicion is if we went back and did more studies, we would find that the rate of fear, particularly of weekly drugs, is going down.
Yeah, I'll reinforce that from my clinical experience. Back in 2014, 2015, before Saxenda was approved, we were very concerned that patients would strongly shy away from the injectable Saxenda in that case. That has not at all been what I've seen. There are certainly some patients that have phobias over needles, but for the most part, that has just not been a significant limitation in practice. I will say the biggest limitation in terms of administration among the medications we're looking at has been the twice daily dosing with the naltrexone bupropion combination. That's just a tough thing for people to remember, particularly because it's not an early morning and then before bedtime administration. It's a morning and midday administration, ideally, and with food. And so, I mean, I don't know, think about it in your own lives. Think about having to remember twice a day, midday, along with food to remember something. So that's been tough for quite a bit, quite a number of people. I run into maybe, single digits, less than 10% that have a problem, have a real strong aversion to an injectable medication.
Thank you both so much. There's a couple questions and we are running time, but let me try to get to Dr. Gold's question.
Hi there. I'm going to ask a question for the clinical experts that I'm also going to ask for the advocacy folks later on. In your review of the evidence, it looks like most of the benefit that was captured in health-related quality of life was on the physical side. And yet there's a strong point that's made about mental health issues all the way through. And I'm wondering from the clinical experts' point of view, whether that's what you discover when you're seeing people with obesity. Is it much more that the focus on the conversations is on physical health, or is it more on mental health, or can you not really say?
Well, I'll make a comment then. I think that what the data show that were reviewed is that the effect on physical health as measured in these trials was greater than the effect on mental health. However, there was an effect on mental health as well. From the clinical perspective with patients, my own observations is that the effect on mental health is what the patients spend time reporting to us more commonly than physical health, although if you query it, they will tell you about both. But patients do, when they start these medications, frequently have either fear or misperception about what the purpose of the medication is. And this is one of the educational challenges that we have. If you look at the average duration of use of these medications, it's measured in months rather than years, and yet this is a lifetime disease. And so I think that occurs in part because people take the medications and they don't always work. As I've already mentioned, there's enormous variability from patient to patient. But far more commonly, people have the sense that they could lose the weight with the medications and then perhaps maintain the weight loss without the medication, so they stop that. And and then other people feel that they can lose the weight with medications and the cost is prohibitive, so that they have to stop the medications. That's an access issue. And then the third group of people think that the medications are no longer working because their appetite is no longer suppressed or they're no longer losing weight, without recognizing that the maintenance of weight is also an effect of the medication. When you put all that together, a lot of the potential benefits on mental health are a little bit diminished by all of these anxiety-provoking concepts that I just described. And so patients will be focused on that. What's going to happen? Is this going to work in the long term? Frequently, they've had experience, almost always, they've had experience with diets and lifestyle-based approaches that have not worked adequately over the long term. And so they have a lot of nervousness about that. And I suspect that some of the limitations of the mental health improvements or the mental functioning improvements have to do with those fears.
Thank you so much, Lee. I recognize that we're a couple minutes over, but I just wanted to try to sneak in a question. I saw Dr. Lavelle's hand up. Do you want to try to sneak it in?
Sure. Maybe I can just make this brief, but one thing that I think I've heard the clinical experts allude to a few times is the patient variability. And I wonder if we're missing some of the benefit of semaglutide by thinking of it not just as its own therapy, but as an option that you can add on when other therapies don't work, so that overall you're sort of increasing the effectiveness of all therapies by having different options for different patients. You know, so if you think about optimizing across all of the different patients, having this different option actually adds to the effectiveness in that way. And that was one of the things that's not captured in this assessment.
My response is yes. I would say that two things to say about that. One is, in real practice, we look at the outcomes of the weight loss and we make decisions as to whether to continue based on whether the patient's doing very well, both in terms of the weight loss and in terms of the improvement in the rest of their health and the rest of their functioning. And then the other piece that you mentioned is we frequently use, in practice, we frequently use these medications in combination.
Thank you.
Thank you so much. And so we're a couple minutes over, but reasonably well on time. So I will transition now to introducing Dr. Ki-Boom Kim, who is an assistant professor at the University of Illinois at Chicago, who will present the economic modeling.
Okay, thank you for the summary and the discussion on the clinical evidence of the obesity management options. Now we are going to summarize our approach and the outcomes of our model-based economic assessment on the strategies for the weight management. So my name is Ki-Boom Kim from University of Illinois, Chicago, and I will lead the presentation on the economic model. Next slide, please. Before having the summary started, I would like to briefly acknowledge the contributions that made this economic assessment possible. Hillary Lian and Dr. Kanya Shah assisted the research team in developing the model and identifying the inputs. Dr. Daniel Touchette provided the valuable advices and inputs throughout the entire project. Researchers had no conflict of interest to disclose. Next slide, please. The overall goal of this economic assessment is to estimate the long-term cost effectiveness of the 4 treatment options compared to the lifestyle modification for weight management in patients with BMI greater than or equal to 27 with weight-related comorbidity or BMI greater than 30. The 4 treatment strategies include semaglutide, liraglutide, fentanyl topiramate combination, and bupropion naltrexone combination. Next slide, please. We developed a Markov model to estimate the cost and effectiveness in the United States from the healthcare sector's perspective based on the ICER reference case. Calculation was performed for the lifetime horizon with an annual discount rate of 3% for both cost and clinical outcomes. Model was running on 1-year cycle basis, and the outcomes include cost per quality adjusted life years gained, cost per life years gained, and cost per equal value life years gained. Next slide, please. Our model assumed that the cohort entered the model without diabetes and would receive 1 out of the 4 treatments along with lifestyle modification or lifestyle modification alone. The patient group starts from the Markov stage without diabetes or major cardiovascular complication. On BMI and other risk factors of each cycle, study cohort will have a chance to develop comorbidities for the next cycle that include myocardial infarction, stroke, or other chronic vascular conditions. Then patients with myocardial infarction will have a chance to develop heart failure. BMI is a key indicator of developing diabetes, and both BMI and diabetes are the risk factor for the cardiovascular comorbidity. We included the trajectory of cardiovascular comorbidity in the patient developing diabetes after they received 1 of the treatment. Next slide, please. Target population was defined based on the review of clinical trials. Study cohort was 45 years old with average BMI of 38. We assume the study cohort is dominated by female with 80%. Baseline smoking, hypertension status, and systolic blood pressure and average HbA1c was defined from the review of clinical trials as well. The core characteristics were key risk factors in developing comorbidities in our model. Patients in our model are on the active obesity treatment for the lifetime horizon. Next slide, please. Here we have several key assumptions. First, costs associated with the treatment discontinuation were included in the first model cycle, meaning that we address the cost associated with the treatment discontinuation from the beginning of the model and follow those patients who continue the treatment in our model. Second, the proportion of actively treated hypertension is a function of BMI. However, hypertension would not have a significant influence on the incremental cost effectiveness ratio. Third, blood pressure is equally well managed across all weight loss treatment in patients with hypertension. Next slide, please. Here are the efficacy outcome inputs, including the percent weight change after patient received the treatment along with lifestyle modification or lifestyle modification alone. The weight loss input values were identified from the review of clinical trial, and they match it with the network meta-analysis. For the average changes in HbA1c, we included the HbA1c reduction after the use of semaglutide or liraglutide. The HbA1c reduction effect independent from BMI change were identified from the review of clinical trials. Next slide, please. One of the key approaches in our model is using risk equations to calculate the risk of developing comorbidity. We used a non-laboratory-based cardiovascular risk prediction model from Framingham cohort, which is available from American Heart Association, to calculate the incidence of cardiovascular condition based on the predictors, including BMI. Diabetes is a risk of developing cardiovascular condition as well as clinical outcomes influenced by the weight management. We used the exponential regression that associated BMI and average HbA1c to predict the annual onset of diabetes using the previously published data. Next slide, please. We anticipated that obesity-related comorbidities increase mortality and will eventually influence life expectancy. To calculate the mortality influenced by the cardiovascular conditions or diabetes, we extracted age-specific general population mortality from the United States life table, then applied the relative risk associated with the specific comorbid conditions. The relative risk inputs were identified from the literature review. Next slide, please. Treatment cost of lifestyle modification was calculated based on the review of literature. For each active treatment arm, we used the federal supply schedule price to calculate the annual treatment cost. The cost of semaglutide and liraglutide exceeds $10,000 per year and notably higher than the average cost of the other two treatment options. Next slide, please. To address the treatment cost in patients with comorbidities, we identify the cost of each condition from a review of literature and publicly available data sources. All the cost inputs were inflation adjusted to 2022 value. Next slide, please. Because the quality adjusted life years is our primary measure, the value of preventing comorbidity were converted to the health utility. First, we factored the age-related health utility changes in our model, then applied the association between the BMI and utility change. Next slide. For the health state utilities for the comorbidities, we applied multiplicative utility of each of the chronic conditions calculated from the previous study to address the significant decrease in the quality of life during the acute condition management phase. This utility of acute myocardial infarction and stroke were identified and applied. Next slide, please. All things together, here are the base case discounted results out of our model. Semaglutide is the costly option, followed by the liraglutide and bupropion naltrexone combination. Also, semaglutide was the most effective treatment, which is followed by the phentermine and topiramate combination. Next slide, please. The incremental cost and effectiveness values in reference to the outcomes of lifestyle modification alone are presented in this slide. Across all the drug, non-intervention costs associated with the onset and the treatment of comorbidities are lower than the non-intervention cost of lifestyle modification alone. Based on the non-drug cost, semaglutide shows the largest cost-saving offsets, but the overall cost of semaglutide is highest out of the compared strategies, owing to its comparatively higher treatment cost. Next slide, please. And we calculated the value from the previous incremental cost and incremental effectiveness. The incremental cost per quality adjusted life years and per equal value life years gained for semaglutide compared to lifestyle modification alone are slightly over 230,000, which exceed the lower or upper bound of the widely accepted willingness to pay threshold. The incremental cost effectiveness ratio compared to the lifestyle intervention was lowest in phentermine topiramate combination. Next slide, please. To test the robustness of our cost effectiveness and to identify the most significant inputs, we performed a one-way sensitivity analysis. Next slide. Changes in the utility associated with the BMI change was the most influential inputs for semaglutide. And next, weight lowering effect of each treatment compared to lifestyle management and the baseline HbA1c had a considerable influence across all 4 treatment options. Next, baseline BMI was one of the top 5 significant inputs varying the incremental cost effectiveness ratios across the 4 treatment options. Cost of diabetes also has a significant influence on the incremental cost effectiveness ratio in our model. Next slide, please. To address the multiple inputs influence in our model simultaneously, we ran a probabilistic sensitivity analysis that results in acceptability curves presenting the likelihood of acceptance on y-axis at varying level of willingness to pay threshold on the x-axis of this chart. The likelihood of accepting phentermine topiramate combination was above 80% at the willingness to pay threshold of 100,000. Next, the likelihood of semaglutide being accepted at the higher willingness to pay of $150,000 per quality adjusted life years gains was lower than 50%. In general, glucagon-like peptide-1 receptor agonists are unlikely to be cost-effective at generally accepted threshold due to the high cost of medication. Next slide, please. Obesity-related conditions may lead to a decrease in productivity, and societal perspective analysis cover this indirect cost into the calculation. Taking the societal perspective into our consideration, phentermine and topiramate became less costly and more effective compared to the lifestyle modification. Incremental cost effectiveness ratios of the other treatment lowered in the societal perspective analysis, but did not cross the generally accepted threshold level. Next slide, please. There were uncertainty and concerns raised for the other comorbidities such as cancer or chronic kidney disease. To address the concern, we added Markov states to the model and tested the influence of the association between weight changing effect and cancer or chronic kidney disease. By the inclusion of additional comorbid conditions, either cancer or chronic kidney disease, the analysis resulted in the incremental cost effectiveness ratios around 10 to 15% lower than the base case estimate in general. However, this scenario did not significantly influence the final conclusion. Next slide, please. In scenario analysis, we changed population characteristics and cost of medications where generic combinations are available. The projected cost-effectiveness ratio are modestly influenced by changing the population characteristics, such as higher baseline BMI or male to female ratio. Specifically for the semaglutide and benzamethopyramide that provides a larger weight loss benefit, the incremental cost-effectiveness ratio decreased, but neither scenario changes the cost-effectiveness ratios largely. Next. Applying the cost of generic replacement for the benzamethopyramide combination or bupropion naltrexone combination, both generic combinations are cost-effective compared to the lifestyle modification alone. Specifically, benzamethopyramide combination is less costly and more effective in this generic combination scenario. Next slide, please. Considering the high cost of semaglutide, we calculated the acceptable price range after applying discount. The benchmark price would be achieved once 45 to 57% discount is applied to the current wholesale acquisition cost of $17,600 per year. Next slide, please. Several limitations should be considered in interpreting the study findings. First, a model-based cost-effectiveness assessment may not include the full potential impact of weight loss. Some conditions were excluded due to the concern over double counting of weight loss benefits. And second, risk equations may have limitations when attempting to predict impact of drug treatment-related weight loss. And lastly, outcomes in subpopulations with larger potential benefits, such as younger individuals, women with the childbearing age, or underserved population, were not specifically addressed because analysis was limited by available evidence. Next slide, please. We received several constructive comments on our model-based approach from experts and patient group. It was recommended to assess shorter treatment duration of 2 years to reflect uncertainties around the utilization of anti-obesity medications. We choose to simulate the outcomes of lifetime treatment because it is possible that the weight cycling may have adverse health effects. Also, due to the uncertainty in the true benefits of temporary weight loss following short-term use of anti-obesity medication, we choose to omit the shorter treatment time until additional evidence can be available. Another comment we received was our assumption that myocardial infarction as a prerequisite to developing heart failure. This may underestimate the incidence of heart failure. We generally agree with the comment. However, we anticipated that the incremental effect of medication for weight loss on non-ischemic heart failure would be expected to be minimal. In addition, there was concern about the double counting of the benefit related with this issue. Lastly, there was concern on the treatment benefit associated with other relevant comorbidities. Here, we would love to discuss that some comorbid conditions were not included in the model due to the paucity of evidence regarding the impact of weight loss on these conditions and possible overestimation of the benefit to weight management. And one of our sensitivity analysis demonstrated that additional comorbidity has a nominal impact on the final result. Next slide, please. In our conclusion, long-term weight management with the semaglutide or liraglutide was not cost-effective given commonly accepted willingness to pay threshold. Of the studied options, benzamethopyramide, in addition to lifestyle modification, was cost-effective given commonly accepted threshold owing to its comparatively smaller net acquisition cost. Bupropion naltrexone combination was cost-effective at higher threshold only. And then benzamethopyramide is cost-saving, and bupropion naltrexone was cost-effective when prescribed generically. Next slide, please. Thank you so much for listening, and we are moving forward to the Q&A session that can be led by Dr. Daniel Tushin.
Thank you so much for your presentation. Rob, I see you have questions.
Yeah, thank you very much, Dr. Kim. So I have a question just to clarify what might be seen as a disconnect between the very, very impressive weight loss findings versus the fairly meager improvements in quality adjusted life years. So what I'm taking away from the model, and perhaps Steve Atlas would want to comment on this as well, is that what is being reflected there is a very limited impact of all of the agents on those proximal risk factors for morbidity and mortality, which would be systolic blood pressure, LDL, and A1C. Is that a fair assessment?
I mean, I think that there were important differences in quality adjusted life years gained, lifetime estimates for those. These drugs are effective and they are impacting long-term outcomes for patients. So I think the issue is primarily around the cost effectiveness, not, these drugs are costly at $13,000 per year. And so the benefits that we see, the offsets, are not are maybe not sufficient to support such high prices. I mean, we've compared our models with other models, and we're seeing similar benefits in our model as what other models have seen. So we feel confident that our model is accurately predicting long-term benefits of treatment. Does that answer your question?
Well, I just would like to go back to the base case results,
yes,
where we're looking at a comparison in qualities. I mean, we're really talking about now these outcomes, and the quality differences between lifestyle modification and all the treatments are really not that impressive. You have less than one quality adjusted life year. So my assumption is, yes, they're effective in reducing weight, but we're not seeing, at least in the models, the translation of that reduction into real risk reduction for morbidity and mortality.
Yes, I guess that is an accurate statement. I mean, we're seeing differences with treatment of approximately 0.3 years when we look at life years gained. So, and then with qualities, it increases to about one quality gained with the treatments.
Dan, you may want to comment on the effect of discounting on this, because a lot of these outcomes are late long-term outcomes. And so actually seeing a quality difference just short of one is actually fairly big for a lot of drugs. But Dan, you might want to just say a little bit more about that.
Yeah, thank you, Steve. That's helpful. I mean, clearly in these types of models, when discounting is applied, events that occur far in the future have a lesser benefit observed in the present when we're doing the model. So it's likely that some of the benefits that we would see in the if we look at the undiscounted results, those would show a much higher benefit than the discounted results, because those long-term benefits are reduced. So that might be part of a response to this question.
Thank you. Greg, you have a question?
Yeah, I wanted to ask about the target population being based on the clinical trials. That makes sense to me, but I was wondering, with the approval population age range versus the clinical trial population age, there was a sensitivity analysis around sex there. I didn't see the same attention to age. Do we know how the analysis would change if we looked at the approval age versus the US population instead of the clinical trial population?
We did not do an analysis evaluating the impact of age on outcomes. And that's something we could potentially look at in the future, but no, we did not consider that.
Steve.
As noted in both our presentations, there's a lot of potential benefits that could be accrued by treating younger patients, particularly young women, of childbearing potential, but there's really no data that we could use for either effectiveness or for modeling. So Greg, it's a good point, but it's just a data-free zone from what we were able to find.
Perhaps do we even know how that population differs, though, of the eligible population, even if we don't have the outcomes and on that side, even that sort of might tell us how far off this is from what the treatment population is.
Steve, did you want to?
Yeah, I mean, it's true that the population that we model is based on the data that we had, and that that may not reflect the broader population of patients with obesity. Obviously, going to a younger population, as Steve Pearson was saying, the potential benefits of treatment could get worse simply because we're going a lot longer. As mentioned, there may be other benefits. So I think broadly as a group, we felt uncomfortable going into an area where it would be a lot of speculation.
Yeah, just speaking on the model as well, you know, our benefits are primarily modeled using the AHA-ACC risk reduction equations, and those predict 10-year outcomes. So looking at a younger population with a lifespan of 40, 50 additional years, we're not certain that these equations would accurately predict risk in that population as well. And then as Steve pointed out, lifetime treatment, patients would incur the cost, and they would likely be at lower risk at the earlier stages of their life. And so even though total lifetime benefit may grow, the costs would probably grow at a much higher rate, and because risk is lower earlier on. So they might look less cost effective if we were treating younger populations.
Lee, did you have something to chime in? It looks like.
Yes, I would comment because the availability of effective drugs is relatively recent, and the effectiveness of the drugs is better but not ideal yet. If you look at bariatric surgery, what you see is that the benefits take time, so that the mortality benefits really start to be statistically significant after about 3 years, and morbidity benefits also take a fair bit of time. And I suspect that that's because we're dealing with a chronic disease with chronic complications, not only the ones that are being included in this model, but also additional ones like cancer, for example. And so I suspect that one of the challenges here is that you're looking at outcomes data that are limited in time frame, substantially limited in time frame to a year, and that it's going to take a lot longer studies, 2, 3 at a minimum, to begin to see more accurate assessments of the true long-term benefits.
Thank you. Steve Kogut, I think you have a question.
Yeah, thanks. Well, first, hats off to the UIC team. You always do such a superb job modeling such complex issues. I thought the very clear and straightforward. A couple of questions related to some things that I thought might have a larger impact on the cost effectiveness ratio. One is in the trials, there were more than 40% of individuals who were pre-diabetic, and in the sensitivity analysis for the model, seemed like the boundary didn't quite get high enough to approach that population. So that may have been an uncertainty not it's captured maybe as well as it could have been, perhaps. And then 2 is how healthcare sector, if this is a healthcare sector perspective, how did you capture the lifestyle modification costs? It seems like that's also being borne in the model, but yet again, with the healthcare sector perspective stated, I wondered about that as well. So those 2 questions. Thanks again.
All right, thank you, Steve. Yeah, so the reason we chose to focus on this population without diabetes is because we've already done cost effectiveness analyses of these drugs in patients with diabetes, and we know the effects of the drugs in patients with diabetes. We wanted to capture primarily the effects of the drugs in patients without diabetes, and where weight loss is the primary benefit of these therapies. And I would imagine that individuals with pre-diabetes, the benefits would be somewhere intermediate between what we've observed here and what we would see in the model that was developed a couple of years ago, evaluating the cost effectiveness in diabetes. But yeah, you bring up an important point. There may be some additional benefit with pre-diabetes in delaying diabetes. We did build in a component of delaying diabetes in the model, but we did not consider the impact of the GLP-1 agonists in reducing hemoglobin A1C once a patient has diabetes. That is not part of our model. And can you remind me the second question?
Capturing lifestyle costs in the health sector perspective.
Yes, so we did apply, and maybe Keebum, you could comment on this. I'm pretty certain we applied a cost for lifestyle management, right?
Yes, I applied the cost based on the several interventions reviewed from the clinical trials and the research. So basically, we assume that patients will visit the physicians and the nutritionist a couple of times per year. The cost, kind of the minimum cost increment is related with the lifestyle treatment, lifestyle modification.
So just to extend that a little bit, there was some cost and some benefit included in the model for lifestyle modifications. And for the most part, because lifestyle modification in clinical trials was applied to both groups, we would expect to see very minimal to almost no difference when we're looking at the incremental benefits of lifestyle modification. But that was captured in the model. So where there may have been some differences in effects, we should have captured
that. Dr. Gold, I think you have a question.
I have a couple of questions. I'll try and make it brief. The first one is, in terms of the health-related quality of life values for the decrements in health-related quality of life, I see that there are 2 references of where you got those values from. I wonder, can you just tell us a little bit about how those, what kinds of scales were used to collect those decrements? I guess I was a little surprised that they were as small as they were.
All right. So I can answer your second question first, and then I'll ask Dr. Kim to respond to the sources. These are similar findings or similar inputs that were used for past cost effectiveness models. We had a pretty important discussion around how we would apply these utility measures within the model and which were the best inputs. The inputs that we used are consistent with past inputs used in other models. So we felt pretty comfortable that these were reasonable. The Sullivan study I can comment on because we've used that several times in our analyses. That study applies to EQ5 or is a large population-based EQ5D study that looks at disutilities and utilities associated with a number of different conditions, including the cardiovascular conditions that we included. Do you want to comment on the other?
Yes, in terms of the calculation for the multiplicative utility, we extracted values from the Sullivan study and compared the weight between the general population they used compared to the patient who actually had the condition. So we compare kind of the relative ratio and relative rate of the decrease in the utility to calculate the multiplicative value. And for the disutility of acute stroke and acute myocardial infarction, we identified one study from the 2015 written by the Mazda, sorry about that. And the method they used was they tested some kind of the survey type of the questionnaire for the time trade-off between the patient and for different kinds of scenario, patient who experienced acute stroke for 6 months to 1 year versus patient who do not experience acute stroke or the acute myocardial infarction. So compare this utility from that and compare from the other studies, we are pretty much sure that we generally capture exactly the decrement in the acute conditions for that specific condition.
I see, thank you. So one other question. I know, and this bears on our later conversation, but it's important. When you make the decision to decide that the treatment would go for a lifetime, this is really for the clinical experts. I remember from my medical education that there's sort of set points in terms of what the body returns to in terms of weight. And is there any thought that one would actually stop treatment after a couple of years and see what happened with people who had returned to a lower weight that was more of a set point, or is that theory all gone? And because that's a long-term amount of, you know, both risk of taking a drug as well as an expense of taking a drug.
Yes, thank you so much for your comments. Got it.
Was that directed at our clinical experts?
Yeah, that was a clinical expert, and you know, because it feeds into the economic model.
Scott, do you want to comment on that?
So that question has been evaluated in relatively short-term studies, a year, for example. We know at a year, very clearly, the hormonal changes that occur with weight loss, hunger hormones essentially going up, satiety hormones essentially going down, which then generally drive people to eat more and regain the weight. At a year, those are the same that we see after a couple months of dieting. So we know, if you will, and the set point is, you know, there's no, it's not really a physiologic concept. It's a way of thinking about it. But we know at least at a year that trials show that is a concept that seems to be the case. We don't have longer term data on that. We don't know that hormones are still doing the same thing to drive weight regain at 5 years, at 7 years, at 10 years. Now, anecdotally, it seems that would be the case. And for the most part, when we treat patients for obesity, we continue those treatments ongoing. There's often tweaks to it, changing from one medication to another, adding an additional medication. But I'm not aware of any data that would explicitly answer that question physiologically over a longer period of time than just a year or so.
Thank you. Tara, I think maybe time for one last question, Dr. LaBelle.
Yeah, thanks. Just a quick comment, then a hopefully not too long question. Just related to the utility values, related to the point that the EQ5D was used, I just wanted to point out that that instrument only has one question related to mental health and 4 questions related to physical health. So, and there, as opposed to other measures that do have additional questions on mental health. So there could be some concern that the mental health impact of interventions could be somewhat undervalued by using something like the EQ5D. So that's just something to keep in mind as we look at the benefits of this intervention. The second thing is, I just wanted to know if the economists could just talk briefly about how they handled adherence in the model, both in the first year and then in the lifetime extrapolation.
Yes, and so adherence was a tricky one with this analysis, as was the 2-year treatment time horizon. We are using equations that predict a complete prevention of a myocardial event rather than a delay in a myocardial event. So the ACC-AHA risk equation is really an association between weight, or BMI, and these events that occur, these cardiovascular events. And what we found, and actually is borne out in another recently published study that the company was involved with, is that when you treat for a 2-year time period, the cost effectiveness ratio actually improves dramatically. And it's because the lifetime benefits of having avoided a cardiovascular event accumulate over time, whereas the costs end at 2 years. And so we felt very uncomfortable with not knowing what happens to people who discontinue or what happens to people who stop therapy at 2 years, because that's what's recommended. We felt uncomfortable building that into the model because we felt that it would bias our cost effectiveness estimates too much. So we did include short-term discontinuation because of side effects. We did not include long-term discontinuation of treatments in the model.
Thank you.
I recognize we're a couple minutes over. If I could sneak in a really quick question, if that's okay. Can the modeling team, or maybe even Steve Atlas, comment on why not include surgery as a comparator? I understand that the data may not be there, but it seems like a relevant, like patients would want to know. I understand that maybe lack of data, but the comment on the decision to not include surgery as a comparator.
Maybe best. So we, in our scoping phase, Jason, we actually spoke with our clinical experts about that, and one of the real, and also patients, in terms of, is it really a choice? And what we heard was that that was a different, that it would be hard to directly compare them, because the choice, as I think someone was saying, between an oral drug and injectable drug, maybe not so big, I think, as Scott was commenting on, but the difference between choosing between surgery and medicine represented a much bigger step. And so for that reason, we focused on that. And then the other thing, and I think Dr. Kaplan has spoken about this, is that some of these drugs are starting to approach the effect of weight loss surgery, but not quite there yet. So, so in the future, that may actually be a very good one, but based on our scoping phase, we didn't quite feel that that was the key question that we wanted to answer at this time.
Got it. Thank you so much. And so with that, we're only a couple minutes late, but I will transition to public comment and discussion. My understanding is the first speaker, Dr. Jason Brett from Nova Nordisk,